Great. So we're a couple minutes past the hour, so I think we'll go ahead and get started. Welcome, everyone. Good morning, good afternoon, good evening, wherever you're joining us from. My name is Liz Colway. I'm Senior Manager of Community Building and Digital Engagement at Sabin, primarily supporting the Boost community. So I recognize a few familiar names in the call and a few new ones as well. So again, just welcome everyone. This is actually our 6th Bright Spots webinar. From the first round of Bright Spots, which we released earlier last year. Our conversation today is on our Bright Spot around support for routine immunization, PEI, EPI synergy in Sindh, Pakistan. So I'll introduce our presenters in just a moment, but before we get started, I just wanted to again, remind you of a few of the Zoom functions, which I'm sure at this point you're quite familiar with. One, we'd like you to introduce yourselves in the chat box. Just be sure to choose the option for all panelists and attendees so that we can all see your response. So welcome everyone who's joining us there in the chat. Throughout the webinar, if you do have questions, we ask that you use the Q&A feature for the webinar. That way, folks can vote up or down an option so we can make sure we answer the question by the end of the webinar. I think those are all of my logistical points. So one last slide that I want to share with you all is just on the Bright Spot series, which again, I think at this point, probably many of you are familiar with, but wanted to kind of share a little bit more about Bright Spots initiative. So from immunization and conflict settings to community engagement to bottom-up approaches to planning, there's innovation occurring at all levels of the system. So our Bright Spot series really shine a light on the work that is happening on the ground, also seeks to inspire immunization professionals everywhere to learn, adapt, and take action in their own communities. So the story that we're sharing today is from the first round, which has transpired to become an exciting annual story sharing competition. So you can actually stay tuned. We have stories from our second round of Bright Spots, which will be coming live on the website in the next couple months, along with additional live engagements. So definitely watch out from emails from the Boost community regarding those stories. The stories from the first round include a collection of 10 submissions from 6 countries, including Ethiopia, Nigeria, Tanzania, India, Cameroon, and today's story from Pakistan. So with that, I just want to introduce our 2 speakers that we're privileged to have with us today. Dr. Tariq Masood, he started his career in the Department of Health in the Sindh province as a medical officer in 1999 and worked as a disease surveillance coordinator in the district EPI focal person and SIA's focal person for 5 years. He joined WHO Pakistan as surveillance officer at Karachi for AFP surveillance and SIAs at the district level. He was later on promoted as senior surveillance officer for the Sindh province and then as NPO WHO. He overall, in total, worked for WHO for 9 years. He then joined JSI in February of 2016 and has been working as a senior immunization advisor to them and up into the present right now. We're also joined by Pat Taylor. Pat is a project director and senior advisor at JSI. She's a public health planner by training and has worked in the field of immunization for the past 3 decades. Pat managed the program in Pakistan that we are reporting on today and worked with Dr. Tariq and his colleagues to document their experience. So welcome to them both. And with that, I want to hand over the mic to Pat, who's going to be presenting and then passing it over to Dr. Tariq. So over to you, Pat.
Thank you, Liz. This is Pat Taylor. It's a pleasure to be with you this morning, and thank you for joining us. Good morning, good afternoon, good evening, wherever you may be located. I am just going to start by telling you what we'll talk about today, and also then giving some introductory points, and then I'm going to turn it over to Dr. Tariq, who is the person who knows the most about this particular topic. We're going to go through a little bit of the background of the immunization situation in Pakistan. I'm going to talk a bit about PEI, EPI synergy, in case that's not a concept that you're familiar with. And then we'll jump into the approach that we took in Pakistan in this project, some of the key outcomes, the barriers, and some of the solutions that were found, the lessons learned, and then looking ahead, and some questions and answers at the end. Go on to the next. So starting with the background, just to make sure that we are all familiar with the terminology and some of the abbreviations that are used here. So EPI, everyone knows, is the Expanded Program on Immunization. In Pakistan, it started in 1978-79. Can we go back? Sorry, we lost the slide. Right, fine, that's fine. In this presentation, when we talk about EPI, we're really talking about the routine immunization functions of the immunization program. PEI, of course, is Polio Eradication Initiative that started globally in 1988. Pakistan is one of only 2 remaining polio endemic countries, as you all know, I think. The situation improved dramatically with polio through 2018, but 2019 saw a sharp rise in cases. And that appears to have continued in 2020, although there have been some issues with surveillance in the pandemic era. And I don't think the numbers actually for 2020 are certain yet. The complications of coordinating and including synergy generally means the coordination of PEI and EPI activities, teams, resources to achieve the objectives of both, which would be more children fully covered with polio, with polio vaccinations and with the routine vaccinations in Pakistan, which are 11 at this point in time. They have 11 antigens. The complications of coordinating the EPI and PEI is that one of the things is that they have different lines of authority, different structures, and different incentives in Pakistan. So EPI is managed by a national program manager, and then at the provincial level by EPI project director, district health officers, and there are vaccinators that are actually under this line of command at the field level. The PEI, the Polio Eradication Initiative, is managed by an emergency operations center that was established in 2014 at the national level, and it has units that are present at the provincial and the district levels, and each one of them has an EOC coordinator. So these are parallel lines, even though they are under the same Minister of Health at the top level. Vaccinators are critical to both EPI and the PEI, SIAs in particular, campaigns. The work on campaigns has been incentivized and on routine immunization or EPI it has not been incentivized. So there's some push and pull there in terms of what vaccinators actually have been spending time on or had been spending time on when we started this project. As of 2016, when we began this experiment in operationalizing PEI, EPI synergy in Pakistan, there were few evidence-based approaches to actually achieving synergy, and none of them had been taken to scale. Things are improving somewhat in Pakistan, as Dr. Tariq will tell you about. But when we started, there was very little sort of synergy that was actually happening on the ground. I'm going to turn it over now to Dr. Tariq, and he's going to walk you through some of the background on EPI and PEI in Pakistan, and then talk about our approach in the rest of the presentation. Dr. Tariq?
Thank you so much, Pat, and thank you everyone for joining, and a special thanks to Boost team for giving this opportunity to us. May I request Liz to kindly allow me to share my screen, please?
Yes. You should have access now.
Can you see this?
Yes, we can.
Okay, so as Pat has already mentioned about the PEI and EPI synergy, what we are talking about today. So I will just give a brief background of the project, which was 5 years RMNCH strengthening project in 16 districts in Sindh province out of 29 total districts in Sindh from the period of 2013 to 2018. And then support to the Department of Health, Government of Sindh.
Tarek, I'm sorry to interrupt you, but you need to go to slide mode or your slides aren't going to work correctly.
Is it okay now?
Yes, that's fine.
Okay, I thought it was already. Sorry for this. So the support to the Department of Health and Government of Sindh was provided in the fields of family planning, immunization, MNCH, like chlorhexidine, healthy baby breathing, kangaroo mother care, CMOG, community mobilization, and nutrition services, etc., etc. 16 districts participated in the PEI EPI synergy, for which we will be talking about today in some fashion. In 8 districts, the intervention was more intensive. 3 districts started in February 2016, 5 were added between August and October. The intensive PEI intervention ended in December 2017, spanning approximately 18 months of the total life of the project. This is the map of Pakistan, and this is showing the vaccination coverage from the DHS Pakistan Demographic Health Survey, which held in 2012-2013. You can see Pakistan is in 2020 population was around 221 million in total, and the coverage of routine immunization for fully immunized children was 54% in Pakistan. So around 46% of children did not get their all due vaccines in that time. And then the intervention of this synergy was implemented in Sindh province, which has approximately 51 million population with 1.8 million approximately newborns every year. Sindh province was reported to have 29% of fully immunized children, which is way below the global standards to have 80% plus coverage. And worst part of the story is that only 14% of children were reported as fully immunized in rural parts of Sindh, resulting in repeated outbreaks of polio, measles, and other vaccine preventable diseases. So the task was obvious to support the government in Sindh province, which is second most populated province of the country, to revert the situation of VPDs and improve the routine immunization coverage. If you see along the course, the admin reported coverage has usually been high. This is, you can see with this yellow set of bars having 84% of measles coverage, but in contrast, the FIC reported in PDHs, as I just mentioned, was 29% in Sindh province, and mix confirmed in 2014 that it was a little improvement. Is 35% of fully immunized children were found in the survey, which was done through UNICEF support. Now, talking about EPI synergy in Pakistan, we had, like in other parts of the country, the polio was managed by the EPI team everywhere, in Pakistan as well. But in 2012 and 2013, as Pat mentioned, that the independent emergency control center was established for polio to gather all these stakeholders under one roof, which is supposed to be led by the government. They realized that after this bifurcation, there is need of these two projects to talk with each other, to work together, so that the common goals of polio eradication, measles elimination, these all can be achieved. The first thing which we found for synergy and documents was in 2012, when first meeting of Pakistan Technical Advisory Group on polio eradication recommended that PEI explore synergy, especially in high-risk districts, where we had more cases of polio and everywhere. And in the following events in the global by the IMB and then WHO MRO reports and National Emergency Action Plan, which is NEEP for polio eradication, there's a repeated endorsement of all those things. And from here, the authorities like health minister, the secretary, the EOCs, they also issued the orders to implement the EPI PI synergy. But what we found was everything was available in the documents, but nothing at the ground level, unfortunately. So despite these endorsements, there continue to be challenges to achieving the synergy, and I will be talking about the challenges in more detail in coming few slides. Okay, well, the ultimate objective of PEI EPI synergy is to working together to reach additional children for both polio and routine immunization. When you go to vaccinate children for polio at house to house, at their doorsteps, they refuse and they ask for where are the other antigens, where are the other vaccines for our children. So if we add this routine immunization in the package, the coverage for polio was automatically increasing. And unfortunately, as I mentioned earlier, the demonstration in the field was not existing. We couldn't find that any initiative which has resulted in reaching the additional children. So the approach which we took was mixed model for public-private partnership. We took a health system approach to improving routine immunization through better planning and implementation. Our goals were to register every child under 2 years of age and reach every pregnant woman, improve recording, reporting, monitoring, and supervisory system, ensure mobility of vaccinators and their training and supervision, engage the communities through local civil society organization under the umbrella of Rural Support Program Network, RSPN. And we had 3 more sub-awardees in this working with RSPN in different districts. Now the key actors, I would say at the provincial level, we had Project Director PSN, whom we were assisting, who was leading, and their teams. Then PEI Emergency Operations Cell Coordinator and team, after looking at the results, they were so much supportive and helpful, and they wished us to continue and help them in the difficult districts. And then JSI team, of course. It's not only the country team, but also is a big staff support at the headquarters. I must say that JSI has a unique system of working. We had the honor to work with persons like Robert Stinglass, Pat Taylor, Folaki, Laura, Vanessa, Malik, and most of them. And this idea of PEI synergy was brought up by Dr. Abdul Malik Hashim, who worked with us in the this project, and when he visited and he looked the situation, so he brought all this, and then from there on I took it and implemented in the field. So at the district level, our district health management teams, who were of course was leading the polio campaigns repeatedly and all other things. And the main key actor, I would say, that our district immunization officers. These were recruited by our project. These were independent, not under the government, and they all were doctors. And from the field, they really did marvelous job in the field. I'll show you in the coming slides. And of course, vaccinators and their supervisors. Then MIS team, who registered each and every child along with their antigens and also the due doses and the other activities which they did. Local CSOs representatives in the field at the Union Council level, the lowest administrative area was a field assistant, followed by their provincial and district, provincial and country teams. And of course, the village volunteers, who are the gatekeepers. If they do not allow, we cannot enter inside the house and vaccinate children. So they were really also crucial in our project. Right. So the project supported districts and polio cases by date of onset. If you see, this is the map of Sindh province, and then the yellowish color is telling us about the project supported districts, which are 16, although it is 18, but I'll not go into the details that we adopted some districts. So the intervention was implemented in 16 districts. The circle is indicating where more intensive districts where PEI synergy was implemented in depth, and then stars showing the district with district immunization officer, which were 16. So So these are the cases of wild poliovirus type 1, which occurred in 8 districts, and you can see majority of MCHIP districts, our project districts were harboring this before we took over from the for the routine immunization intervention. So altogether, it was worse situation as majority of the divisions were involved in at the time when we took over. And see this, the data of onset in 2016, very close relations with each other. Now, as I mentioned, the very first and foremost important intervention was carried out through the district immunization officers. We involved them in all sort of activities related with the planning, then implementation of those micro plans, preparation of the outreach plans, and the capacity building of the vaccinators, and above all, monitoring the vaccinators and the vaccination staff in the field so that we can validate what has been planned is implemented actually in the field. They were supposed to visit the fixed centers, EPIs, the outreach sites, and take household clusters to see the progress and their results. So that package really helped us. That these were our eyes and ears in the field, and we were monitoring for them and providing them technical support so that this vehicle can be moved in fast track. It's not moving, sorry. The other activities in the activities in the intensive EPI, PEI districts. These include we started with the microcensus and used data to update EPI and polio microplans, and missing population were included in the EPI microplan. Community engagement through village local focal persons. We listed and lists were exchanged with the EOC and district polio control rooms. Social mobilization through CSO's network, management information system for registration, tracking of due dose and defaulters, monitoring of performance and reminder messages to caregivers, advocacy to provincial authorities and DHMTs to make sure vaccinators were released from polio campaigns, the repeated SIAs, I would say, to conduct RI outreach services by order of EOC, EPI, and DGL. Now, every SIA, whenever it was happening 8 to 10 times a year. And every time, every month, 15 to 20 days of the vaccinators were used in the polio SIA. So work for the routine immunization was suffering because their targets were not met as they were out from their own duties. Capacity building for mid-level managers, vaccinators, supervisors, lady health workers, and data entry operators and others. So the micro census was done in house to house when the field assistant from the local CSOs were registering household survey for the children under 2 years of age and any pregnant woman, and they were transferring this data into the MIS. Then community mobilization, you can see that the female community mobilizer was conducting the session in one of the most remote districts of the country, which is Tharparkar, where they were providing the key messages for which disease are covered under EPI, what is the schedule from where they can vaccinate their children, what is the next dose date, and also if there is any AEFI, what should be done in that case. So that was quite helpful in gaining the confidence of the communities. Now then, we also provided the extra support. I mean, there are not metallic roads everywhere in the country. Talking about Tharparkar having around 20,000 square kilometers area, 90% plus in desert. So there's no vehicle which can go. So we provided the support to camels, and where there were island and children were not being reached, so we provided the boats and the fare for these boats to reach to those children who are living in the islands and cannot be covered otherwise. So the vaccinators and field assistants were visiting those villages as well. The activities in intensive EPI districts continue as prepared plans for outreach during polio campaigns. The first thing which we did was, of course, got the vaccinators released from one district, which is Tandolaya. I'll show it in another graphic picture. And then we prepared their outreach plans during the polio campaign. So when polio campaign starts in an area, the EPI vaccinator is also conducting routine immunization coverage, which was not happening before. And prepared list of due and default children by area using microcensus plus PEI zero dose children. Provincial provided petrol, oil, and lubricant support in addition to the motorbikes to vaccinators and advocated with state to increase their allowance. Monitored and provided supported supervision during outreach, shared feedback regularly with authorities for corrective measures. Of course, the decision makers were being informed to take actions to improve the situation. And then continuous the advocacy for and promoted the synergy approach. Now, in summary, activities driving progress was house to house registration, like that is microsensors, micro planning, outreach based on microsensors, fuel, oil, and lubricant plus motorcycles facilitation to vaccinators traveling, community mobilization and tracking the caregivers' reminders when they were getting messages on their mobile phones that their child is uh, due for this and this vaccines, active monitoring and problem solving, capacity building, like different sort of trainings were conducted. The activities above are implemented under polio eradication initiative and expanded program immunization, that is PEI synergy. Now, the first arrow showing here the start of this model from one of our district, Tandolaya. I'm thankful to the DHO, who released 11 vaccinators who were uh, from polio perspective were not performing well. They were released and we utilized them to vaccinate to conduct the outreach sessions for all the antigens. In the 9 union councils, they were working and they conducted 28 outreach sites, and I remember they vaccinated more than 500 children, not only for polio but other different antigens. And with this positive initiative in only one district and only 9 union councils really encouraged us to advocate with the provincial level, get the letters for implementation in other districts, and we worked through DIOs in all other districts. And as I mentioned in the previous slides, the intervention activities, and with the passage of time, the number of union councils where the number of vaccinators involved kept increasing. And ultimately in this, after 1 year of the activity, you can see highest number of union councils, the 320, where 536 vaccinators were released from the polio campaign to work for routine immunization during the SIS period, and they conducted 2,700 plus outreach sessions. If they cover 10 children per session, you can imagine how much difference this was bringing in only 4 days of the campaign through this small activity. And then, of course, in the September, we had the highest number of outreach sessions in across the country. So altogether, in the synergy model, we had more than 16,800 outreach sessions conducted during the polio days, and more than 300,000 children were vaccinated for different antigens, including OPV and IPV. So the problem we are having that if you succeed with the repeated SIA and achieve a zero polio case, but you have to have uh, really good routine immunization coverage to sustain that success. If it is not there, then we are seeing what we are having repeated. Right. So the next was, of course, the key outcomes I would discuss with you, and these include um, the village registration, as I mentioned in the beginning. The yellowish bars are showing district-wise number of villages registered as the baseline, and the blue are those which are number of villages counted in MIS at the end of the project. Total of the baseline villages were 23,000 plus villages, and by the end of project, 28,500 plus villages. There was 20% increase in number of villages, which we picked from this synergy model. We took the, I'll explain this in the coming slide as well. So the number of children registered from 0 to 23 months of under 2 years during the life of the project in eight intervention districts. You can see around 313,000 children were registered at the baseline, but total registered children in the LIFA project were more than 830,000 children. Because in 18 months, the newborns were kept enrolled in the MIAs, and they were followed for vaccination. And of course, when we compared the microplans, we found out missing villages, which I'll explain in a while. Now, previously, as I mentioned, the main issue for the vaccinators was they were not getting released from their polio duties to work for their EPI in their job. I mean, the culture of EPI is to having the fixed site where the vaccinators are working and then perform the outreach services. So with this activity of PEI, repeated PEI, they were not doing the outreach services. They were mainly either having involved in the polio campaign or maximum working in the fixed center. So the communities which were not reaching to vaccinators were left, to the EPI centers were left alone. And you can see all the 8 intervention districts, with the passage of time, the number of outreach sessions increased, which were conducted more than the previous time. I mean, with every campaign, and this resulted in vaccination of maximum number of children. Then routine immunization coverage, Penta 3 and OPV 3 increased dramatically in this in these 8 EPI intervention districts. We had a total of 27% children at the baseline who received 3 doses of Penta and polio. When our project ended, we took this 27% and we reached to 79% of the children receiving 3 doses of Penta and OPV and IPV. And you can see at the, like Tata, at the baseline it was 4% and 90% at the end line. And then of course, Kashmir. And these are the one of the most difficult districts geographically, and then with the other law and order situation, security wise and difficult terrains. So most of the districts were really difficult to reach to the children, but we could succeed with all these intervention activities. Now the results of PEI EPI synergy in district Sajawal. This district was not in our intervention districts in the beginning, but at the request of the Emergency Operations Cell, that is EOE, when 2 cases of polio were reported from this district, they asked us to please take care of this district as well. So we started, and when we did the micro census, we found hundreds of children of 18 months, 19 months, 20 months who did not receive a single dose of polio, a single dose of routine immunization. Not for SIA, but for routine, they didn't, receive. So we applied the same model, DIO, microcensus, and POL, and all those things, and we accelerated the what you call vaccination services. And you can go right to the last right bar, where you can see measles 2 coverage from 644 reached to 13,000 plus. Same applied for measles 1. And most important to me for polio education, this is IPV. You can see the highest number of children were vaccinated for the IP, and that really helped for polio education initiative as well. Now, the previous slides were, you can say, these were sort of reported coverage from the MIS, but this map is talking itself. This is the data of measles, neonatal, and diphtheria cases in the Sindh province, in the intervention district, non-EPI, PEI intervention districts on Sindh. And you can see, and this is by WHO and by government independent data, not by JSI, not by the project itself. You can see the difference. After the intervention period, and when we saw this in the May 2017, in the final months of the project, we found out that there are lesser number of measles cases in PEI, EPI synergy districts under MCHIP. No case of polio reported in that year and in the next year as well. And even we had a good control from this. So summarizing again, micro sensors, micro planning, facilitation of vaccination with motorbikes, capacity building, community engagement, caretaker reminders, and close monitoring through supportive supervision, problem solving at grassroots level through DIOs and household and the head office immunization team and project. This resulted in the registration of 830,000 plus children and 348,000 plus pregnant women. Monthly vaccinator outreach activities reporting 550 motorbikes were provided in addition to 4x4 vehicles, camels, the boats. 3,557 district health staff were trained and oriented on 8 districts. More than around 1,900, 19,000, I would say, village volunteers. The community focal persons were engaged. They were informed about the routine immunization. What are the antigens? So they are really, I mean, the force for the program. So again, the due dose reminders sent to the children communities, and we supported in not only polio SIAs, but MNT, measles, and other synergy activities. The outcome, you, as I mentioned already, routinization, then this is the number of children in front of you, around 650,000 children will receive 3 doses of pentavalent, 79%. If I see from BCG till measles one, 52%, and tetanus elimination, 227,000 pregnant women received 2 doses of tetanus. It is 65% available. Talking about the barriers and solutions, what we faced in during this hurdles. I mean, this whole process.
Tarek, we're losing your voice. Can you get closer to your mic?
Is it okay now?
It is. It keeps going in and out, but keep going.
Sorry for this internet issue. So barriers we face were involvement of EPI vaccinators and repeated anti-polio SIAs. And the way we overcome it by we continuously advocated with the provincial and district authorities. And we had frequent transfer of district health officers. Imagine in 18 months of project in one district, we had transfer of 10 to 11 DHOs in one of the district. So that was really help in halting the progress of and continuity, of course. We had advocacy with ministry and EOC to retain the DHOs in their post for a longer time so that they can continue the intervention. Then inconsistent implementation of micro plans, outreach plans, and we had close monitoring and supervision through DIOs, provision of motorbikes, POL, and field assistance. Low level of awareness of communities in remote villages, organizing awareness sessions with village focal persons and communities, and of course the important role of CSOs. Initial micro sensors and EPI microplans were not complete. Villages and families were missed. What we did, we triangulated the EPI microplans and microcensus data with the polio SIE microplans. And we found hundreds of villages and thousands of children that were initially missing. And we found that polio microplan were more comprehensive and routine microplan were missing those. So we enrolled those children and basically went for the vaccination of those children as well. Capacity issues of district health management team and vaccination staff, mid-level managers training for managers, and IIP for the vaccination staff in addition to on-the-job coaching. District health officers and commissioners reluctant to release the vaccinators during campaigns, fear of missing polio targets, continuously advocated and shared results with district and provincial level decision makers. Lessons learned. So the lesson learned, of course, target the highest decision maker. I think the first thing first, due to high turnover, the team kept losing valuable time engaging with and introducing each new district staffer to the approach. Securing a memorandum of understanding with the province before starting activities would have been more effective and less time consuming. Then, of course, design for the context. The resource allocated for routine immunization must be reviewed periodically to ascertain requirements and mobilize resources. In our intervention initiative, we use motorbikes, 4x4 vehicles, boats, camel carts to enable quick access to hard to reach areas, increasing the number of families that were identified and served. These are missing ingredients in the effort to maximize PEI and EPI results. The same approach will give you the same results. Gaining acceptance for innovations or even minimal changes was difficult in our context, even though existing methods hadn't yet achieved the target of polio eradication. With the new synergistic approach, both RI and PEI vaccination coverage will be increased. Looking ahead, you can say the way forward in transitioning this successful package of intervention, we ensured that the Details of the PEI and EPI synergy approach were shared with the federal, provincial EPI teams, EOCs and district authorities, and with WHO, UNICEF, and the donors. Many of the project's interventions were adopted and continue to be implemented with support from the partners. Government of Sindh recruited 1,800 more additional EPI vaccinators based on our analysis provided to them that we are understaffed and one vaccinator cannot cover 250 plus villages in one unit council. Purchased additional motorbikes for vaccination, increased their monthly allowance for petrol, oil, and lubricant. WHO initiated enhanced outreach activities with Gavi funding throughout the country, focusing on a special micro-planning and outreach plan preparation and monitoring model, which we initiated. Then DIU monitoring model was adopted by UNICEF and funded by Gavi. Third-party monitors are working in Karachi right now in Hyderabad, and UNICEF is supporting government to scale up the approach to all of the Sindh province. Now, advice for others facing similar barriers. As I mentioned, achieving and sustaining polio eradication requires a strong EPI program. The resource requirements for both programs, PEI and EPI, must be met to achieve and sustain the results. Long-standing endorsement of PEI EPI synergy must be operationalized and put into action on the ground in all districts. And the last thing, of course, be bold, try something new, measure your results, share them with key decision makers, and don't give up. Your innovations can help save the lives of women and children. I thank you very much.
Thanks so much, Dr. Tarek. So right now we're going to open up for Q&A. So if anyone has a question or answer or question, feel free to submit it in the question box or through the chat. It looks like we have a few questions coming in. So the first one is from Ava, and she said, do you see the possibility for synergy with other health interventions? For example, neglected tropical disease drug administration or vitamin A?
Right, thank you, Eva. Actually, vitamin A is a mandatory part of polio eradication initiative as well. Just would like to inform you that every 6 months in the NIDs, in the National Immunization Days in Pakistan, we provide the vitamin A to the children from 6 months to under 5 years of age. So that is already there. We had what you call synergy with, we did that, we applied that when there were other health interventions in happening side by side. So boosting can also answer on this.
Great, thanks for your answer. We have another question coming from the chat. This is from Robert. So with Pakistan still only one of 2 countries that have never eliminated polio despite massive investment, and now a circulating vaccine-derived poliovirus to deal with it, as well as also poor routine coverage nationwide. Have the Ministry of Health and all global polio partners in Pakistan and elsewhere taken a look at your synergy experience? And what is the status of your project now?
Thank you so much, Robert, and honor to listen to you again. Yeah, actually, at the end of the project, as I mentioned earlier, Malik and I myself visited the country offices of WHO, UNICEF, National EOC, and Federal EPI, and we briefed them and we shared our findings and all those things with them. And the Gavi mission with the other donors and the EPI partners like WHO and from federal to provincial level, they also visited 2 of the districts of MCHIP. So after, providing all these information, as I mentioned, that the things were taken up in bits and pieces. As I mentioned, WHO took one intervention, UNICEF took other, but the MCHIP project, which was USAID supported, that ended, the second part of your question, that ended in 2018, and we could not, unfortunately, got funding to continue this intervention. So if you ask me, the major things we could contribute was to provide them the insight in-depth analysis for recruiting the new vaccinators, the provision of mobility support, And of course, the DIO, which was agreed upon by the Chief Minister and the government twice, the summary was initiated, but it could not get through the Finance Department, unfortunately. But I understand your question that the project could not be continued.
Great, thank you. I'm checking to see. Again, if you have any other questions, feel free to send them through the chat or the Q&A. One question we got, what key actions were taken to make sure that the goals and intentional outcomes were communicated at all levels?
Right. So we had a mechanism of sharing the data on regular basis with EPI, provincial EPI, provincial EOC, federal EPI, and Director General Health, with the request to share this with the district from their channels as well. Of course, our staff was working at the district, and we were regularly sharing those in the review meetings. So one thing was monthly sharing of this data. The second thing was when the quarterly EPI review meetings were coming, so we were providing the information and sharing this data, their progress. I remember when the coverage, the outreach sessions in one of the district, in our intervention district, which is District Sijawal, it was only 10% in a month. And then a quarterly review meeting was taking place, and all the partners, donors, they were sitting, and the health minister was chairing the meeting. And I briefed the chair that when the low coverage of District Sijawal was shown on the slides, and I told them that despite of all the support which we are providing to them, they have only conducted 10% outreach sessions in comparison to what were planned. So at that time, really, the health minister has called it DHO, and of course, from that, the people got message that no, this is not a joke. When the resources are there on the table, better we utilize them fully. So, and of course, at the end, we had periodic meetings with the donors and with the health authorities. As I mentioned, the health minister and secretary, where we were providing them the regular update of the project.
Great, we got a few more questions coming in. One is a question around how the immunization team convinced the people of the villages to vaccinate their children who may not have enough knowledge and don't know a lot about vaccines. And they may believe that these vaccinations are chemicals that are harmful for them. So I guess dealing with issues of vaccine hesitancy in the community. Can you share a little bit more about strategies to combat that?
Yeah, this is a really important question. And to me, my learning, if I conclude my learning in this EPI and PEI, especially for routine immunization is the knowledge of community. If the people know, they will really take their children to the EPI centers and all the vaccination sites to vaccinate their children. If they don't know, they will not bother to take their children and go out. So what we did, as I mentioned earlier, we developed the force of the village volunteers. For example, if we were, when all the villages were enrolled in the MIAs, we also enrolled the well-known person in those villages, like gatekeepers. So the next target was these persons. We took their mobile numbers, and from which we were throwing the awareness messages through mobile phones to them, number one. Number two, we arranged the small community awareness session through the field assistants, through the vaccinators, and through our DIOs. So these were given information that, okay, these are the antigens, these are the diseases against which these antigens can protect their children to be contacted, and these are free of cost. And this is the schedule. So the thing which is really one of the barriers, when the people don't know, they don't take their children to even the EPS center, which is our outreach session, which is happening in the next district where they are living. But when they don't know what is it and what is all about, they will not bother to carry their children to them. So we hardly found any resistance among the communities. When they were informed, they were very happy, and they accepted routine immunization and the teams open-heartedly, and even they facilitated. We kept providing them the list of the children's vaccination status in their villages, which we found in our monitoring visits. So that was really, I mean, encouraging to find that these people, when they are informed and involved, they really own the vaccination program, who were just getting the OPV at their doorsteps, and then were thinking their routinization will also come to their doorstep as well, which is not in the case of EPI. So the outreach sessions were conducted in their nearby areas, and EPI centers were what you call services were strengthened. So that really moved the wheel, and we could achieve the success.
And there was a specific question around any challenges that you might have faced or coming from religious leaders in communities in particular.
Yeah, this is a question from Tahir. Thank you, Tahir. Actually, as I mentioned, that these 8 districts, intervention districts, were in the rural Sindh, and you will hardly find any refusal, religious from any kind. But in urban part in Karachi, I can give examples from experience from working in WHO or where we are working currently. We developed the urban immunization roadmap. In rural part, we hardly found any refusal, but in urban context, yes. So in urban context, when we were visiting them, we had IDIs and focus group discussion in this while developing the urban immunization roadmap. And when we started the discussion, they were very harsh that polio you are bringing every day to our children, and this and this and that, nothing else. So when we started to inform them there is not only polio, but there are 11 diseases for which government is providing the free of cost vaccination, they were quite convinced. When we were informing them about pneumonia, diphtheria, diarrhea, measles, tetanus, and hepatitis B, typhoid now, of course, and meningitis. So they all were really convinced. So I believe if you convey the right information to the people, you will find a little resistance at all.
Great. So another question we have, so Pakistan is introducing an electronic immunization register. Is that helping with updating microplans and following up on due doses and defaulters? How would an ERegister affect the CSO's role? Is the government of Sindh, or are there any other donors supporting CSOs to play the same kind of role they played in the PEI EPI synergy approach?
Yeah, so the CSOs were funded by our project line item, not by the government. They were independent, and we were monitoring their progress. As I mentioned, that in 8 districts, 3 sub-awardees were recruited, and their field assistants worked at the union council level when they enrolled all the villages, and they entered those in the MIS through MIS team. Then we had village-wise data of children under 2 years and pregnant women, and what was the status of vaccination of each child who was registered. So suppose if there is 30 children in a village, 5 of them have received all the antigens, we targeted 25. And from there, we prepared the micro plans, the outreach plans. And then the sessions, outreach sessions were planned accordingly. It was monthly review meeting when the vaccinators were bringing their data of previous month, and we were then based on that the vaccination status at the village level. We were preparing and targeting the villages with the highest number of children who were due and defaulters. So that is one part. The other part is that when these were entered in the MIS, we were tracking those children from the copies. We were having printed copies, and at the glance we were knowing that, okay, which village has to be given more focus, or like 2 days or 3 days of work, and which village is actually does not need a single day in the week or a month even. So that was really helpful. And then this benefited both programs. As I mentioned in the middle, that District Sajawal having 2 polio cases when our intervention was implemented with all the antigens provided to the children. The acceptance for OPV was also increased. The number of unreached children was limited, decreased, and we could vaccinate more children, as I shown in one of the graph, that highest number of IPV was provided to that district having 2 polio cases. And as I mentioned earlier, we did not have polio case afterwards.
Great, thanks. So I think we have time maybe for one more question. So we have a question from Laura. Per the earlier questions, can you please speak to your suggestions on how to help the Sindh province to operationalize the RI roadmap, including community engagement for sustainability?
Yeah, that is really good question, Laura. See, the basics are the same. I mean, which are implemented in different countries and which have already yielded the results. And there's no need of invention of new wheel. But the point is of implementation. What you plan is not implemented at the ground until and unless you. I mean, as we mentioned in the presentation as well, which we found out that EPI program was very much under resourced. So once you have to look into it very, deeply, that what are the actual requirements of the program. You cannot run the program based on the 20 years previous targets or number of vaccinators. Now it is really rapidly growing population, especially in the urban areas, which have their own dynamics. And the province, especially the Sindh province, is all sort of population and demographic extremes in the province. I mean, the urban posh areas with the slums and then the deserted areas. So you cannot have one strategy for all. District-wise, specific action plans need to be prepared, and resources need to be allocated. Timely release of all those resources and properly utilized, which are monitored and really implemented in the field. So to me, these are the same old recipes, but implementation is the real challenge, I would say.
Great, thanks again. Since we only have about a minute left, sadly, we won't get to everyone's questions. We can certainly answer them offline as well. So I just want to share one last slide. Let's see if I can do that really quickly. Great. So again, just thank you all for attending today's session. We hope you found it informative and engaging, and we invite all attendees to join the Boost community to learn more about our upcoming events and engage with your peers around this story and the other bright spot stories in the coming weeks. We'd also love your feedback and request that you fill out a brief survey so that we can ensure that these sessions are as useful as possible. So I think my colleague just put the link to the survey in the chat box. So please click on that and fill that out after the session. Last but not least, I'd like to extend a special thank you to our presenters today. If you have any questions for them or for Boost, feel free to reach out to our general inbox, which is info@boostcommunity.org. And with that, I want to wish everyone enjoyable morning, afternoon, evening, wherever you're joining us from. And thanks again to our presenters.
Thank you so much, everyone. Thank you.
Bye, everyone.